We'll get started here in just a few minutes. We'll let people get a chance to remote in, so I can see people are starting to come into the room here. If anyone could just do me a favor, if they can go to the chat section and just say that they can hear my voice, and you can also see the screen, the actual slide on display. All right, perfect. Thank you. Thank you so much. All right, we're going to start here in about 30 seconds. Okay, welcome everyone. My name is Brent Garvin, the Senior Product Manager for Imaging for Plan MECA USA, and delighted that you could join us this evening for our lecture entitled COVID Considerations and Screening for Obstructive Sleep Apnea. Excuse me. Before we get started, let me go over a couple housekeeping rules. If at any time you want to ask a question to one of our speakers, you may do so by using the Q&A icon at the bottom of your screen. The speaker will either answer the question during the lecture, most likely, or if the question they want to wait till the very end, they'll wait to the conclusion of the lecture to answer the question. But for the most part, they'll probably answer the questions as we go along. We'll reserve the chat function at the bottom of your screen for any technical difficulties you may have, and hopefully we can get them resolved for you in that chat section. Tonight's lecture is for 1 CE, and we will be posting that in the chat section at the conclusion of the course. So stick around and we'll provide you with a link to obtain your CE digitally. So let's go ahead and get started with our lecture entitled COVID Considerations and Screening for Obstructive Sleep Apnea. We have two fantastic speakers lined up for you this evening. The first is going to kick us off is Michael Cowen, who's the founder of Waken to Sleep. That is Plan MECA's sleep partner for sleep apnea, and his executive sleep coach will come on after, and that is Chad Wooter. So welcome, Michael, and welcome, Chad. Go ahead and take it away.
Hey, thanks, Brent. We appreciate it. And thank you guys for joining us. Looks like we got a good sized audience tonight. So we're going to have some fun talking about apnea and actually a random positive related to the COVID virus. So we're going to have some good conversation tonight. We do have about an hour with you guys. We're going to try to wrap it up a little bit before then for some Q&A. So if you guys have questions, as Brent mentioned, please throw them in the Q&A. We'll likely cover many of those answers as we're talking tonight. But if you've got some burning questions, we're here to answer them. So we're excited to chat with you and hopefully give you a couple of nuggets where you guys can go help some patients. Before I get going here with relation to the COVID considerations and the slides we're going to talk about, a few disclaimers. I am the founder CEO of Waken to Sleep. Waken to Sleep is a for-profit company that is paid in cheeseburgers, hot dogs, and kindness from Plan MECA. We are very thankful for them as a sponsor tonight for our CEs. And we're just here to help you, like I said, for about an hour. So without further ado, let's hop in. First thing is, want to cover with relation to screening. When we start talking about the topic of obstructive sleep apnea and the role of a dental practice in screening for this, it's really important that we rewind just a little bit and go back a few years to what the ADA said in 2017. They were pretty clear that it is their strong recommendation that dentists are they are in the midst of the workflow at the very beginning of the workflow in a sleep apnea patient's life cycle, which means that you should be screening. Now, whether you treat for this or not, that's a completely different topic, but screening for it is pretty much a requirement. Now I say pretty much because the ADA doesn't make actual state regulations, that's your dental board. But let me put it to you this way. It's pretty much in line with oral cancer screenings. You don't necessarily treat oral cancer. I'm guessing most of you on the call don't, but there is a clinical obligation, if you will, to screen for that. So if you kind of put this in that same context, because you are specialists of the mouth and the oral cavity, you're uniquely situated in the patient's life to be the predominant screening factor for them. So the ADA says it. We're going to talk about how to do it effectively tonight, and frankly, do it on a team level. If you as the doctor are on here and you guys have either tried this or you're wondering how in the world am I going to fit this into my new protocol, we've got COVID, we've got PPE differences, we've got a completely different workflow than we had. How do we fit this in? We're going to talk about that tonight. But if you will get on board mentally with it's your role to screen, and ideally, if you're screening, there's no one better suited to treat this. If you can add this into your practice, it's not just a fantastic patient support mechanism for their health, it's also a great practice support mechanism for the finances. We're not going to talk about money tonight. That's not the topic of interest. But as we go through this, just know if you are screening and you're doing this for the purpose of treating, it is a fantastic benefit both to you and in your practice as well as your patients. One of the other announcements that recently was made by the AASM, or pardon me, the AADSM, American Academy of Dental Sleep Medicine, is they updated the guideline that their medical counterparts put out 5 years ago. In 2015, the American Academy of Sleep Medicine clearly said that patients who have mild or moderate obstructive sleep apnea, they have a choice. They can either do CPAP or oral appliance, and it's based on the patient's preference. So you have a dual alternative or a dual primary recommendation for mild and moderate apneas. And with severe, we know that they had to go with a CPAP first. If they failed CPAP, they could come back and do an oral appliance. Well, this year, due to COVID, the recommendation from the American Academy of Dental Sleep Medicine is that oral appliances are used as first-line treatment for all sleep apnea, not just mild and moderate, because CPAP use actually aerosolizes the COVID virus. So that was one of the considerations and components that they actually published earlier this year. So that's important to know. Now, guys, if you're walking into this and you've got this article, if you want to get the link to this, it's publicly available. We'd be happy to share it with you. That being said, this document has not changed insurance guidelines or payer guidelines. So just to be clear, this is where the AADSM is trying to push this and where it's going. And we want to make sure that you have all of the relevant information that's happening in real time this year. So the most recent statement from the AADSM here. And then from a screening standpoint, I do want to pause here for a second. Dental sleep medicine is a unique component in a dental office because it's bridging medicine and treating a medical condition. And it's also utilizing all of the tools and skill set that you have as a dental provider. You have hygienists that are doing ongoing screenings and cleanings at least twice a year, ideally, on all of your patients. You see a patient 4 times more frequently than your physician counterparts. So when those patients come into your practice, in the midst of all the changes with the workflow and the guidelines and all of those different things, you've still got people who are holistically ready to talk about health. Now, when I say ready to talk about, that's a varying degree depending on your patients and your population. So tread lightly. But I think we can all agree on the fact that there has never been a time in the world that we can recall where everyone unanimously was so focused on overall health. Now, let me talk to you about health and apnea and COVID. We know that how we sleep directly affects our immune system. The level or quality of our sleep that we get throughout the night directly impacts how well our body is at fighting off disease. There's scientific studies based on that. There's plenty of research that backs that up. How we sleep is how we live. How we sleep is how we can fight off disease. Additionally, there are recent studies that are coming out from Medscape and a few others, smaller populations. They're trying to grab the data because COVID is so huge and so new, but they're seeing a significantly higher hospital admittance rate for apneic patients that are untreated apneics and they have COVID. So the statistical analysis off the surface is showing a higher hospitalization rate for patients who are diagnosed but untreated. And we also know that there's a direct impact from how we sleep on our overall health. So those two things combined, plus the fact that the people that we're talking to, the most important person in this conversation, your patient who's in your chair, who needs to hear this conversation, they're probably the most ready to hear it that they have been in the past because of the health impact. Now, how we position that, the way that we actually talk about it is really going to matter. You don't want to bop somebody over the head with a, oh my gosh, you have apnea. You can't say that in the screening conversation. I think we're already on the same page there. But as we go through this tonight, as we look at the different components, the different buckets of what are we going to look at to get a holistic view of this patient? What are we going to screen for? What I want you to keep in the back of your mind as we go through this content is, how does this directly apply to the conversation I'm going to have with my patient? And Chad Wooters is our executive sleep coach here at Awaken to Sleep. I'm going to pause a second. I'm going to brag on him because I'm going to start to hand this over to him. Chad actually wrote an 85-page ebook for us on the screening protocol that he's going to deliver to you guys tonight. That's a free resource. I think he was going to put it in the chat, but I'm going to ask him to do that. So everybody who's on here attending tonight, you guys are going to get an additional resource, has an additional CE, but the bottom line is it's great content to go through with your team. This guy knows screening. And again, as he goes through the topic, as he goes through the buckets, the clinical protocols, yes, grab onto the clinical stuff. And frankly, as doctors, you guys are going to naturally gravitate towards that because you're good at it. So grab those nuggets, hang on to them, and stay comfortable there. But when we talk about the conversation, I want you to pull that thing that's in the back of your mind about COVID and bring it full force. How am I going to articulate this to the patients? How is my hygiene team going to do this and connect it when you come in for the exam? That's the goal here. If we can leave you with anything tonight, it's how do you have those conversations better? How do you start them, or how do you tweak them to do it better and more consistent? That's the goal. So without further ado, I'm going to hand it off to Chad. He's going to take over the screen sharing here and talk you guys through the clinical components of screening for obstructive sleep apnea. Chad, are you good to go on the screen share?
Yeah, go ahead and stop sharing and I'll take over.
Perfect.
All right, guys. Well, thanks for joining us tonight. Taking some time out of the middle of your week to be here with us. We are going to take a focused look at this screening conversation. And a lot of this conversation actually isn't that transformative from a dental perspective. We're going to go over some clinical signs as it relates to what you see in the dentition when you see patients in the hygiene chair and that workflow component that we've been discussing. But the actual signs and symptoms you're going to easily recognize when you see them. So we're going to show you details on how they relate to airway-related breathing disorders, and really focus on how we apply that conversation with our patients. But not a lot of this stuff is going to transform you. I'm not going to show you any crazy dental tricks. I'm going to show you how to take what you already know and apply a different frame of mind into that conversation. One of the quick things I'm just going to ask you guys, we're monitoring all the attendee lists in the question and answer section and the chat. So there's going to be a couple times here we're going to ask you to participate. So please, if I say raise your hand, use that little raise hand button there. I want to see you're awake and paying attention. And at the end of this, like I said, I'll also share links where you guys can get access to the 85-page ebook. And we've got some just information for you guys who are looking to help more patients with this screening conversation. So let's jump in. Let's see if I've got this. All right. We are screen sharing and everything looks good. So one of the big things that we're going to talk about as it relates to the process of treating patients with sleep apnea, there's 3 steps, just like most clinical things that we do. First, we have to identify those patients who are considered to be at risk for an airway disorder. That's going to take place with everyone on the team, and we're going to explain how that works in just a moment here. Once we screen them and they're considered to be at risk, the next step is for them to actually get assessed. We're going to assess the presence and severity of the condition. So there's two ways to do this. They can either go to an in-lab study called a polysomnogram, or they can do a home sleep study. So we'll talk a little bit about that near the end of the protocol. That's not the purpose of today's training, but that's the next step. Once they do that diagnostic test, they're going to have the results interpreted by a physician, a medical doctor who is specialized in sleep ideally, and they're going to provide a diagnosis and a recommendation for treatment. If they're a mild to moderate patient, then they can obviously be a candidate for oral appliance therapy, and even severe based on the newest guidelines that were published by the American Academy of Dental Sleep Medicine. But even if they are severe and the physician recommends CPAP, then if they're intolerant or non-compliant with CPAP, then they may be candidates for oral appliance therapy at that point. But it all starts with screening. It all starts with starting that conversation off with patients who are considered at risk and trying to convince them that there is something to be concerned about that they can't see and they may not believe. So we're going to talk a lot about how to do that and really talking about engaging with their patients on a way that they understand what we're talking about fundamentally and not just hearing us say something's wrong with you. So how do we do this? It starts off understanding that it actually involves everyone on the team. Real quick, if I can just take kind of a role, is there any hygienists or dental assistants or front office people that are on the call? Go ahead and raise your hand for me. I just want to see if there are any of you guys on the call right now. Okay, awesome. Great. Okay, if you're a doctor, we're gonna do that in a second. So it looks like we've got about 10 or so of those team members on the call. Now, doctors, can you raise your hand now for me too, just so I can see about how many of those are you? This protocol actually involves all of the employees on our team, all of the doctors, associates, and owners, and all of the dental assistants and the hygienists and the front office people. Awesome. Okay, thank you guys so much for participating. I can see you're awake. That's a great sign. The first thing we're going to look at is when the patient walks in the office, you'll notice that we typically have them fill out a medical history questionnaire, especially in light of COVID. I'm sure you guys have had to adjust those forms a little bit, have them sign an affidavit that says, I don't have COVID. I'm not exhibiting the feverish signs or any of those symptoms. But on your medical health history, I wonder if any of these things are on there. Specifically, I wonder if these 4 things are on there. 1, hypertension. This study done by RESMED showed that 37% of patients who had hypertension also had obstructive sleep apnea. The second one I want to look at and see if it's on your medical history form is type 2 diabetes. This study also showed that 72% of patients who had type 2 diabetes also had obstructive sleep apnea. Now, this study does not show causal factors. This is just a study that shows the prevalence of this comorbidity with sleep apnea. Okay, so we're looking at these numbers and saying that patients who have X also have Y and in this frequency, okay? The next 2 I want to look at are obesity and drug-resistant hypertension. 77% of patients who had obesity also had obstructive sleep apnea, and 83% of patients with drug-resistant hypertension or who took 2 or more medications for their high blood pressure also had obstructive sleep apnea. Now, real quick, how many of you guys have thought of 10 patients based on just this one slide? Go ahead and raise your hand for me. We got 5 hands up right now. Okay, 7, 9. We're gonna break double digits. We got double digits. Okay, guys, well, that's how you screen for sleep apnea. I'll see you later. No, I'm just kidding. That's where we start the screening conversation for sleep apnea, at the front desk. And front office people, you guys are gonna be the ones who are going through and remembering to highlight those patients who have any of these 4 major comorbidities or really are exhibiting any of these. Now, a couple of these, obviously, it's a little bit too late to talk to them, but, you know, such as congestive heart failure. But these are things that really are impacting a patient on a lot of different ways, a lot of different levels, whether it be irritation from the medication they're taking or their weight bothers them, whatever it is. So it starts at the front office. And if our front office team is aware of that, then they can make a note of it when they get handed off to the hygienist, the dental assistant, or the doctor. So real quick, before we go any further, I need to ask you guys to do me a favor. I hope you're taking notes. Note taking is really helpful for retention. But if you have a phone or something, I want you guys to pay attention, and I want you to pick 3 of your favorite tools that we're going to use to screen patients. That could be a medical history, that could be an intraoral sign, or that could be a patient complaints or a subjective pain point we'll talk about at the end here as well. I need you to pick 3 of your favorite. I'm going to have you guys chat those near the end when we start talking about protocol. So of these, you know, do you have one of these that spikes your interest in particular? All right. So let's talk about the mouth. Now, like I said, I'm not going to try and go through and really get you guys your mind's blown on what exactly dentally we're looking at from a clinical perspective. You guys are dental clinicians. You guys know that. I'm going to try and take what you guys know dental, and I'm probably saying this wrong, dentally, clinically, and really focus on how that applies to the patient. See, I'm a bit of a nerd, so I love using the super clinical words and talking shop with doctors. That's why a lot of my friends are doctors. So that's a lot of fun for me. But I found that a lot of my other friends, my family, they don't really connect with those clinical words. So how do we talk about clinical things in a way that connects and relates to our patients? So we're going to focus on a lot of that in the next couple slides. And we're going to take some of the intraoral signs that you're already seeing that may be concerns for dental treatment. And we're going to focus on the application as it relates to airway. So the first thing, intraoral crowding. As you can see here, we've got two sets of lines. The white are enlarged, the yellow are normal. When we see enlarged soft tissue structures in the mouth, we can take a gander and see that suggests that there's already some crowding blocking the airway. Now, when I was a kid, I was a little bit mean to my sister, and we didn't have like video games and stuff back then. So we played in the backyard with the hose and stuff, and I'd take the hose and I'd pinch it, shove a dirt clod or dirt in the end of it, and then release the hose, and it would shoot water, wherever I was aiming it or relatively close. That same pinching mechanism that holds the water pressure back and builds it up to release the dirt that was stored in the end of it is the same kind of mechanism that results in our airway collapsing, except for we're not folding our throat over. A lot of times something is clogging it. It's our tonsils, it's our uvula, and oftentimes our tongue. We'll talk about tonsils and tongue a little bit later in more detail, but we'll want to focus a little bit on the uvula. The uvula, no one's born with an elongated uvula. That happens over time as a result of a partial collapse or a narrow airway. When our airway narrows, it actually creates a negative pressure system and pulls on the uvula. That pulling over time is what results in an elongated uvula that drops down below the base of the tongue and into the throat a little bit. Can I see some hands up if you guys see patients with elongated uvulas? All right, apparently no one sees, okay, there we go, thank you. A couple of you guys see patients with elongated uvulas. They're not all that common, but they happen. And that is one of the indicators of someone who has at least a partially collapsed or a narrow airway pulling down on that. These other enlarged soft tissue structures can contribute to that collapse of the airway because when we go to sleep, our body falls into what's called a tonic state. Our skeletal muscles expand and our soft tissue structures lose their muscle tone. And that results in even a more narrow airway. So the airway that we see while a patient is awake in our dental chair is the best possible airway they're going to have, especially if they're sitting upright and not laying all the way back yet. So intraoral crowding, soft tissue structures, that's the first thing we want to look at. One of the tools that we use to evaluate the mouth before we really get into the clinical signs from an intraoral perspective is what does it look like when we just open up? Now, the MALLAMPATI was designed by Dr. MALLAMPATI, who was an anesthesiologist. Dr. MALLAMPATI uses this evaluation to determine if someone is at risk for their airway collapsing while being put under anesthesia. So this is what kind of a workflow we recommend for those who are using the MALLAMPATI. Take a little printout kind of like this, and sometimes you laminate it, sometimes you have this kind of cutout and put it on your office wall. And you have your team say, all right, Mrs. Jones, go and sit up for me and make sure that roughly a 45-degree angle and stick your tongue out. When they stick their tongue out, they're not going to say ah, because when we say ah, it's raising the soft tissue in the back of our throat to check for infection. So we're not looking for that. We're looking for crowding, okay? So we stick our tongue out, and you can use your intraoral camera or the patient's cell phone. It's a great selfie opportunity, maybe even a social media ploy. But you have the patient stick out their tongue, not say ah, and then you look at their mouth kind of like this. So just kind of show you guys what it looks like from my screen. I'm going to stick out my tongue and show you guys my mouth. So we're seeing a couple different things here. That's what you're going to have your patient do. This is what you can print out. You can find us online. We have it on our website for free, I think, somewhere. And there's a different guide and things of that nature on there. So those 4 steps: have the patient sit up, have the patient open their mouth, have them stick their tongue out, and make sure they don't say ah. When we look at the patient's mouth in the picture that we took from outside of their mouth, we're looking at a couple things. We're looking at the base of the tongue and the distance to the soft palate. So in a class 1 patient, we can see very clearly there's a significant amount of difference. We can see all the way around the uvula. It looks like a really open airway. Class 2, we see the uvula drop a little bit below the tongue and we start to lose a little bit of that distance. Class 3, we can barely see the uvula and that distance is closing even faster. In Class 4, we're perhaps not even seeing the soft palate, looking at the hard palate, depending on how big the tongue is. So I wonder, what class are you? It's kind of hard to do right now, especially with our time constraints. So if you have a second on your own time, take a photo with your phone and share what class you are with your dental patients to get them involved in the process. Classes 1 and 2 are considered to be not at risk for an airway collapse, while classes 3 and 4 are considered to be at moderate risk for a collapse of the airway. Now remember, this is done for people who are put under anesthesia, not necessarily while they're sleeping. And it's one method for evaluating risk factor, not the only way, and not the way that we should screen patients all the way through. This is a tool, but not a defining factor. Just because a patient's a 1 or 2 does not mean they don't have sleep apnea. All right. Okay. So what we're going to dive into right now is a variety of intraoral signs. We're going to go through each of these, show you some pictures, and we're going to focus specifically on a couple key ones that are usually a little bit surprising to our dental clinicians. So let's jump right in. If you guys have any questions, please feel free to ask them in the chat. I will attempt to answer them while we're discussing the topic right now. And then additional questions, obviously, if they're not relevant to the intraoral signs and symptoms, we'll discuss at the end. Macroglossia, or enlarged tongue. We talked about how the enlarged soft tissue structures, especially the tongue, factors into helping our patients with sleep apnea. This isn't something that we're not going to help their tongue. There is a surgery that actually is a basal tongue reduction that can be used to make the tongue a little smaller and fit better into the mouth. But the tongue can be a big culprit in collapsing the airway. Acid reflux. Acid reflux is perhaps one of the more interesting ones. See, patients who have acid reflux are probably like patients who have bruxism sometimes, and they'll be like, well, no, I don't. But we need to evaluate if this patient has acid reflux objectively. So how do we do that? How do we determine if this patient has acid reflux and yellowing on the tongue is a result of that acid reflux, or if they were just thinking about us this morning when they went to Starbucks and got that croissant with the cream filled inside before they went to our hygiene visit to get their mouth cleaned? So acid reflux or just extra considerate patients. Pretty simple test, actually. Take a probe or a utensil. I recommend warning the patient, but we'll leave that to your discretion, and lightly scrape the top of the tongue. If you lightly scrape the top of the tongue and the residue comes off, so you have yellow residue, it comes off, that means that patient was just being extra considerate. They definitely had something that they ate that morning or drank that morning that caused residue to exist on the tongue, and it's just a factor of something they ate. If the yellowing is in fact a stain, meaning you scrape the tongue and it does not come off, then that patient has acid reflux. When we have an apneic event, typically there is a collapse right here in the posterior hyperpharynx. This collapse causes pressure to build in our trachea, causing pressure to hit the top of what's called the esophageal sphincter. That valve is what protects the throat from stomach acid. When the valve continually gets hit by pressure over time, it weakens, therefore allowing acid to crawl up our throat and therefore stain our tongue. So again, lightly or gently warn the patient, I'm trying to think about words here, gently warn the patient that you're going to probably be scraping the top of their tongue, scrape the top of their tongue, and if it does come off, then you know it's not acid reflux. If it is in fact stained, then that's acid reflux, and that is related to an airway disorder. Bruxism. There's a study done in Portugal that showed that 70% of people who had bruxism also had obstructive sleep apnea. Of those that had bruxism and sleep apnea, those treated with a bruxism guard had worsened sleep apnea. So of this study, 70% had sleep apnea, and half of those people, when treated with a bruxism guard, had worsened sleep apnea. Now, why does bruxism occur? Is it primary? Is it secondary? We can see that it would make sense that a lot of times it could be secondary, and there's ways to evaluate this. So when you have a patient who's exhibiting bruxism, let's make sure that we're treating primary bruxism or that we're treating sleep apnea. Now, how does this relate to the airway? Why does that make sense? Well, that reaction that occurs when we have an apneic event. So we have oxygen that our body starts to desaturate. Our heart says, hey guys, I'm not getting enough oxygen here. You need to work harder. So the heart starts picking up its beat and nothing's changing. So the brain freaks out. It says, all right, guys, we need to open up the airway. Something's going on. So it sends an electric pulse down to the mouth. And basically it says, all right, forward march. And so you see the teeth, the mouth just kind of do this motion. Now, we didn't go over the diagnosis levels of sleep apnea tonight. That's a whole other topic. But we know that for a mild to moderate apneic, that events could be happening. The stop breathing and the body waking up, maybe the mouth and jaw moving forward could be happening anywhere from 5 times to 30 times an hour to be considered mild to moderate. So if you're like me and you used to do it 20 some odd times an hour, 20 times an hour, my body's waking up trying to fight for this airway. It would make sense that if my mouth is just trying to open the airway by moving my jaw, that I might even be doing it in a consistent pattern repeatedly and grinding my teeth. So we recommend if you do find any patients who have bruxism, make sure that you guys are getting their airway assessed. Make sure that you're ruling out the possibility that there's something else that is causing that bruxism, and that is in fact primary bruxism and not secondary. So that's bruxism, fairly interesting and incredibly impactful for a lot of practices. Scalloped tongue. Now, scalloped tongue is very similar to bruxism. The same mechanism that causes the mouth to go forward and up is the same one that causes the tongue to be thrust forward into the back of the teeth. If this happens 15, 20, 30 times an hour, and in some extreme cases over 60 times an hour, it would make sense that we have impressions that are left on the tongue, right? So not to mention the wear on the dentition from that tongue just continually wearing down the back of the teeth and those impressions being present. So scalloped tongue, a really great factor, a great way to identify someone who might be suffering from obstructive sleep apnea. Attrition, we see higher acid content in the body and just a general decrease in health in our body's ability to process chemicals appropriately. Now, this patient might also need a good toothbrush and some good toothpaste, but besides that, it might be a factor that their body's not able to process chemicals or heal properly. High vaulted hard palate. This is one of the reasons that orthodontics in children is being so talked about in the topic of airway. If we can help children's hard palates grow correctly and help encourage the appropriate craniofacial structures, then we can help prevent the likelihood that they're going to develop sleep apnea later in life. So if they have a high vaulted hard palate, then basically their tongue has less places to go. There's more crowding intraorally, and the airway can be narrower, therefore leading to a higher amount of obstructive sleep apnea events. Tonsils and tonsils crowding. Now, tonsils may not be something that you want to get involved with. I don't think laser dentistry has gotten there yet, but they are a huge factor, and they can absolutely cause sleep apnea or contribute to sleep apnea. Tonsils are a personal favorite of mine. I had tonsils, and I was actually treated with an oral appliance for about 6 or 7 months before I had my tonsils cut out as an adult. Extremely painful surgery, debilitating, especially for a speaker. But amazing thing happened with that. I had my apnea resolved, but I actually stopped getting tonsillitis because of my oral appliance that I had first. So for patients who have large tonsils, you may want to refer them out to an ENT, but don't be afraid to help them with an appliance in the meantime. Because while most people may not be willing to go through the surgery, which was painful, and it did cost a little bit of money, they can move forward with that oral appliance. And that oral appliance was able to help me resolve my sleep apnea entirely and stop getting sick all the time. So tonsils, big factor there. So we've got our intraoral science, we've got medical history, and we kind of start putting this picture together, right? So MALLAMPATI, tonsils, acid reflux, bruxism. And the last thing we're going to kind of talk about here is the various effects of sleep apnea. So we talked about the health impact and the comorbidities associated with that. One we didn't touch on, but drowsy driving fatalities. This number varies from year to year, but a significant amount of deaths occur because of these driving fatalities. Additionally, we see that sleep and brain chemistry and the way that we interact with people, so things like memory loss, impotence, morning headaches, and chronic fatigue, most of these are great conversation starters. I'm going to let you use your discretion on which ones to use for conversation starters, but know that if someone's suffering from memory loss, that can be extremely frustrating. Now, my wife gets mad at me all the time for my memory loss, but the reality is that not remembering that she said to get the mail on the way into the house could have been a sign. Now, I unfortunately work for a company that does sleep studies, so I can't use that as an excuse personally, but some of your patients who are forgetful, maybe that's a sign of something greater going on and not necessarily that they're just a forgetful person, right? So great conversation starters, and these are things that you might already be talking about with your patients. So we've got our going through the beginning. We've got our medical history, we've got our intraoral signs, and our various effects of sleep apnea. The last factor is really looking at forms. So real quick, I'm gonna take a second to talk about forms because it's a very common question that we get. What form is the best form for screening for obstructive sleep apnea? Well, real quick, while we're talking about this, I want you guys to go through this questionnaire. Don't worry about the top 4 questions. Answer yes or no to the following questions. Go through these questions, and what I love about this questionnaire is it doesn't care for excuses. Every symptom has an excuse. Just ask your patient, they'll tell you all about it. But here, if you can answer yes to these questions, take the number that is next to them. So if you look at the first one, have you ever been told that you stop breathing while asleep? If yes, then add the number 8 to your score. By the time you get to the bottom, add your total score together and which category do you fit into? If you're willing to, I'd love to see your scores in the chat box. So I'm going to give you a minute. I'm going to talk about forms while I do this, but answer yes or no to the question and put your score in the chat box so we can see who gets the honorary bragging rights of being the champion of the screening webinar tonight, sponsored by Plan Mecca. There are a significant amount of forms that are available on the market today. You Google sleep apnea form and you'll find tons and tons of pages of resources and documents that are available for download. Even our own website has a significant amount of them. So you have to find the one that works for you. Now, we think that the best approach is one that works for your practice, but this is part of our screener, and it's something that we used actually when we used to bill medical back in the day to evaluate the risk of someone who would be at risk for an airway concern or a sleep disorder. And this was that objective questionnaire. So there's others out there. The MALLAMPATI is actually one of them. You've got the Epworth evaluation, the Stop Bang, the Awaken to Sleep screener. Thank you, Michael, for sharing your score. I have to say, that is probably one of the lowest scores I've seen in a long time. You are less than 1/10 of my score. So thank you. Let's see if we get a few more scores out there. I got Gregory. Sorry if I went too personal with the Greg thing there. He's 6, so second place right now. Jordan, thank you for 13. So as we can see, we already have a couple people, one specifically, who's considered a moderate risk. I'm sorry, high at risk. So this isn't, and remember, this isn't a diagnosis. This is their risk factor. This is the factors that contribute to them being considered at risk, the factors that we're going to use to share with them that we're concerned about their airway issue. So that is a lot of the screening factors, some bit about forms there. Now, I'm going to share a video with you guys real quick, and we're going to jump into this protocol component and really focus on a detailed look at our protocol and the whys and how, what we do with our team. So with that, I'll also try and make sure that we get that ebook link sent out to anyone who gives us the E today. I'll try and get that link over to Plan Mecca so I can send it out to you guys. But just know, we need to communicate in a way that works with our patients and works with our office. So we've just gone through the didactic stuff. Now we're going to go through the workflow stuff. And I'm going to give you guys a second to watch this video, and then we'll jump right in.
It's just, there's all this pressure, And sometimes it feels like it's right up on me, and I can just feel it, like literally feel it in my head, and it's relentless. And I don't know if it's going to stop. I mean, that's the thing that scares me the most, is that I don't know if it's ever going to stop.
Yeah. Well, you do have a nail in your head.
It is not about the nail.
Are you sure? Because, I'll bet if we got that out of there...
Stop trying to fix it.
No, I'm not trying to fix it. I'm just pointing out that maybe the nail is causing...
You always do this. You always try to fix things when what I really need is for you to just listen.
Yeah, see, I don't think that is what you need. I think what you need is to get the nail
See,
out.
you're not even listening now.
Okay, fine. I will listen. Fine.
It's just... Sometimes it's like there's this achy... I don't know what it is. And I'm not sleeping very well at all. And all my sweaters are snagged. All of them.
Yeah, that sounds really hard.
It is. Thank you. Ow!
Oh, come on. Ow. If you would just...
Don't...
Try to see things my way. Do I have to keep
All right, guys. So real quick, if you are a wife or have a significant other or are a man who relates to that, please raise your hand. Make sure you're awake today. We show that video because people don't care what you know until they know that you care. Say it one more time for you. People don't care what you know until they know that you care. So in our screening protocol, we're going to talk about a couple different things. And I'm actually going to stop sharing my screen because a lot of this protocol we're going to demonstrate for you here just right in front of you. So people don't care what you know until they know that you care. And so as we're having this conversation, this protocol is designed to do two things. One, it's designed to interact with your patients with where they are today in a way that communicates that you care. Two, it's designed to be a framework that fits into your office, into your workflow. This isn't a workaround, this is a workflow, okay? So I'm gonna show you guys the framework. I'm gonna explain the key components to how it works and why it works, but you are responsible to implement this into your practice in a way that fits into your workflow, okay? There is no one size fits all for dental sleep medicine. We fundamentally don't believe that here. So take our framework and apply it into how it works in your practice. Okay, a couple things, a couple disclaimers. I'm gonna try and do this in under 15 minutes so we can get some time for question and answers here. But the first thing you should know, in college I took one acting class and I was so good that I got failed for never showing up. It was the same semester I got a 4.2 GPA. So I don't know how that happened. Apparently I was acting as a chair and just did it so well that no one got it. But if I'm about to do what I'm about to do, then your team and yourself, you guys don't have any reason that you guys can have this real conversation with people. The second thing is that what we're about to discuss is a little structured. It's very intentional, and it may seem a little uncomfortable for you or your team to grasp onto originally. So I'm gonna let you guys, I'm gonna actually say, please ask your questions, please give us your objections so we can talk about that. But just know that this is intentional, and it's important that we do things in certain ways that engage people with where they are. We're gonna use social dynamics and social cues that are part of our culture every day to communicate effectively. So if it seems a little structured and it seems a little staged, it will be a couple times, and that's okay. But we're going to do this anyways because this is how we're going to see conversion, and we're going to see conversion to acceptance of home sleep studies and things like that. One last thing about this protocol. This protocol in some of our VIP clients is actually shown to increase home sleep testing acceptance in their practices by over 3 times over the course of 60 days. So people going from doing 5 to 7 tests a month to going to nearly 20, 25 tests a month because they implemented this protocol in their team. We're not talking big practices. We're talking 1 or 2 doctors in a practice, okay? So real quick, just so I can see who the audience is, if you own and operate your own equipment, please go ahead and raise your hand for me. If you're, we also see we've got a couple people who are still raising their hands. If you could put your hands down so I can get a good count. How many people own and operate your own home sleep studies? Okay. Looks like we got 1 or 2. Good. This protocol works regardless if you own and operate your own equipment or you don't. And we're going to have some clear guidelines for that on the end. So it looks like we have a lot of people who don't own and operate their own equipment, which is perfectly fine. Okay. So let's jump in. The way this is going to work, you can see me on my screen here. Mrs. Jones is our patient today. When I'm on this side of the screen, my name is Chad, the hygienist. When I'm on this side of the screen, I'm Dr. Smith. And occasionally I'll be right here in the middle, very rarely to kind of discuss Mrs. Jones' dynamic. And one last thing is when I do this, it means I'm cutting or stopping or resuming. The scene is just a break so you guys can see how we're moving around. So here's the backstory. Mrs. Jones comes into our practice and she's a longtime patient. She's been my patient as a hygienist for a long time. And, you know, she is a slightly elderly woman. She's got some grandkids, not like old, but, you know, early 60s. And just loves life, super active, has a couple grandkids, and is just an amazing lady. She comes in all the time, and we know from her medical history that she has drug-resistant hypertension, and she's at risk for type 2 diabetes. She loves her grandkids. It's a huge part of her life, and that's actually going to play a role in our conversation today. Real quick, while we're going through this, I asked you earlier to write down your 3 favorite things. I need you guys to write or type in the chat box, what are your 3 favorite things we've discussed so far? I'm going to try and take one of those examples and implement it into this conversation in just a second here. So Mrs. Jones comes into our appointment, and she comes in and sits into my chair. And I'm like, hey, Mrs. Jones, how's it going? I'm gonna do my normal dialogue with her and we're gonna hang out. No 3 favorite things yet? Okay, well, I'll keep trying to stall for a minute. We've got to keep on schedule here. We have a limited amount of time. So Mrs. Jones comes in, she's sitting down. I'm looking over a couple of notes and I noticed first and foremost, her medical history. We just had the sleep apnea training and our front office team had highlighted those 2 or 3 things that we're considering: the drug-resistant hypertension, the at-risk for type 2 diabetes, and the medication specifically that she's taking there. When I walked her to my chair, I was also talking to her, and she had mentioned that she lately has been waking up with these headaches just right here in the middle of her forehead, and she's just kind of frustrated by that, but it's okay. And also, you know, when she's driving her grandkids, you know, after school, she picks them up from her daughter who is homeschooling them because of COVID. And so she gives her daughter a break and the grandkids come over for dinner and to hang out a little bit. And sometimes if she doesn't have a cup of coffee, she's feeling a little tired when driving, not falling asleep, just fatigued. And okay, cool. Thanks, Jordan, for jumping in here. So we've got that fatigue going on. We've got the medical history, and we do a MALLAMPATI real quick. You know, we do the MALLAMPATI, and we find out that she's a class 3, right? So class 3. And in her mouth, I just kind of doing a cursory exam. We look at and we see that we've got some BRUXISM going on. Now, as you guys have noticed, I found like 6 things that are wrong with Mrs. Jones. I just need to pick 3. Thank you guys. Thanks, Jordan. Thanks, Don, for pitching in here. I need to pick 3 of these concerns to talk to her because no one wants a laundry list of things that are wrong with them, right? So let's pick 3. I'm going to just pick 3 of the things we've discussed, and this is what we're going to do with Mrs. Jones. This is typically a hygienist, by the way. Occasionally a dental assistant will step into this role, but this is at the regular clinic. We see them every 6 months. So we come in, Mrs. Jones sits, and let's start this little piece. Hey, Mrs. Jones. So as I was looking through some stuff, I had a couple things I was concerned about. One, it looks like, you know, you're taking a couple of medications to your high blood pressure, and that's kind of rough. And I know you've talked about that in the past, and that's something I'm a little concerned about. Second, your morning headaches that you're talking about, that's a little concerning, especially considering that you also grind your teeth a little bit. And I'm a little worried that there might be an airway concern, and I really think you should do a test. Real quick, show of hands. Did I make anyone feel uncomfortable? Did anyone feel like I was trying to sell them something? There should be hopefully no hands going up right now, but no one felt like I was trying to sell them anything in that. I was just communicating from a point of concern. Okay, no hands up. That's a good sign at this moment in time. That was a test. Usually hands go up. Good job, guys. Thank you. So no one feels sold. We're just communicating from a point of concern because we really care about Mrs. Jones, right? She's a sweetheart patient who we just love her being a part of our practice, and we're just concerned about her. And guess what? Mrs. Jones says no. Okay, no problem. Nothing happens when someone says no. We're more scared of the no than any negative things happen than when they say no. We're a little scared of it, and that's fair. But Mrs. Jones says no, and guess what happens? We just keep going. We just do our normal hygiene visit. So at that point, doctors let your hygienists know that they're just going to keep going in their normal cleaning visits. So they're going to start cleaning their teeth, doing that whole thing. Now, the next part of this workflow is based on a typical design of workflow from practices. So it can be adapted, but this is typically what happens. After the hygienist is done cleaning the patient's teeth, they make some observations of the patient, and really they kind of look and say, okay, well, I think there might be something concerning on number 8 and things of that nature. And the doctor comes in and they communicate those dental concerns to the doctor in front of them. And then the doctor gives his clinical recommendation for dental treatments, okay? Nothing about that's gonna change here. Remember, when I'm on this side of the screen, I'm the doctor, okay? Nothing about that's gonna change. We want you guys to do the same exact thing that you've been doing, but want you to add 2 minutes to the end. 2 minutes, that's all we're asking for, okay? So, doctor comes in, Chad the hygienist says, hey, Dr. Smith, so, you know, Mrs. Jones, looks like she's grinding her teeth still a little bit. I know we've talked about occlusal color before, but grinding her teeth. Additionally, it looks like number 8 has a cavity, number 14 has some concerning pieces, and number 52 doesn't exist. So we're good. Dr. Smith says, well, no extra teeth is a good thing. As relates to these cavities, those fixed. I don't think number 14 is anything to worry about right now, but we'll keep an eye on it and see what happens. Great. Nothing changes. Okay? Doctors, if you're on the, those of you who are on the call right now, this is the first part of the script, the protocol that you need to pay attention to, and it's actually vitally important. So what happens is you're going to go through this whole dental review like normal. And then at the end of this interview, after you're done giving your clinical recommendation on the dental side, you need to look at your hygienist in front of the patient, and you're going to say something like this. Hey, Chad, is there anything else we need to talk about? What we did there is we basically, from a conversation perspective, we actually created a period, enter, and indented. We created a whole new conversation, a whole new topic, whole new, well, really a whole new start to the appointment. We're now talking about something entirely different than the dentistry that we just talked about. This one step, those 5 or 6 words, maybe I miscounted my words there, but those couple words will actually reduce the amount of times a patient asks you, what is the dentist doing with airway? Guarantee it, okay? So, Chad, is there anything else that we need to talk about? Now, I'm gonna go to the hygienist part here. Now, hygiene, doctors, I need you to pay attention. This is very, very important. I'm gonna try and go where you can see me a little better. And I'm gonna clap my hands, and that's real time, okay? It's as if a doctor had just asked me a question as soon as I put my hand down. You'll hear the clap in the AirPods, okay? So, okay, lighting's not good. I apologize, guys. Okay, so let's go. You know, Dr. Smith, I was talking to Mrs. Jones earlier, and I was just sharing with my concern about her drug-resistant hypertension. She had mentioned to me that she has some headaches in the morning lately, and that coupled with her bruxism, I'm really concerned about an airway issue. Would you mind talking to her about that? Okay, let's break that down because this is honestly one of the most critical parts. Hygienists, you guys are the trusted advisor for the patient. You guys are the ones who have the relationship. They see you for longer than any other medical practitioner, basically in most fields, with small exceptions. You guys are probably friends with a lot of your patients. And when you come to them with a point of concern and you show it in your actions, in your voice, in what's called a pregnant pause, it makes it a very serious conversation. Anyone have kids in here? Kids in the room? Hands up if you got kids. I've got young family members, and I've got a little bit of a scary voice, I've been told, when it comes to kids anyways. And so I remember my little brother, who was a couple generations younger than me, he got in trouble for doing something stupid. And he comes up to me, and I just looked at him and I go, Jacob, and I just sat. Jacob started confessing to all kinds of things that he would not have gotten in trouble for if I had not used a pregnant pause. A pregnant pause is a social dynamic that we've created as a culture. And when we do that, when you're in the room with someone who doesn't respond right away, when they think about their words, when they take a big breath or they chew their lip or anything like that, it drops the temperature in the room just enough to feel it, just enough to know, to communicate that this is a serious thing. Okay? So, hygienist, very, very, very important. Pregnant pause, 2 or 3 seconds. Bite your lip, take a big breath, chew your cheek, whatever you do. Count for a few seconds and look at the doctor, and you're going to say the same exact 3 things you just did. Okay, doctor, next thing you're going to do is you're going to take whatever form, screening form or medical history form, whatever forms you have in your practice, hold those up and not hold them up to the patient. You're going to look at them and look at your patient like you've never seen them before in your professional career. You're now looking at them through the dental sleep medicine eyes, okay? Maybe do another MALLAMPATI real quickly, look at her bruxism, look at her chart real quick. Maybe you got a computer and you're spinning around doing that whole thing. You look there. And this is what you say to Mrs. Jones. Mrs. Jones, patients who exhibit signs and symptoms, like what Chad's bringing up here, are such as, the bruxism, the morning headaches, and the drug-resistant hypertension are considered to be at risk for an airway concern. And they have 2 choices. One, they could do an at-home test. That's a test where we work with a third party that will ship you a test, and then you can test, and then they'll have that read by a physician and give us some idea of what's going on. And the second option is you can go test in a hospital setting in a lab. And it's a little difficult with COVID right now, but I believe there's still options. Which would you prefer? Doctors, very, very important. when you ask the patient, which would you prefer, then wait for the response. Likely, they will choose one of the two options you've given them. Now, one quick objection I always get with this is, well, I don't want to feel like a used car salesman. I don't want to give them two options. If there is a third option, I would love for you guys to share it with me. But this workflow is based on the fact that right now, the next clinically appropriate step for any patient who's exhibiting signs and symptoms for an airway disorder is to do one of two things. They can either do a home sleep study or they can do an in-lab study. If the patient truly elects to do an in-lab study, then do yourself and your office a favor and actually write them a referral for a local sleep center, because in 6 months when they come back and they haven't done that because it was over $1,000 copay and they wanted to have them sleep in this uncomfortable bed with someone watching them for all night, then you have another opportunity to bring this up as a valid concern. The other option is a home sleep study. A lot of guys on here, a lot of you don't have home sleep studies, and that's okay. There's companies out there that do shipping to patients directly on behalf of dentists. So you can use a third party like that. If you own and operate your own equipment, then you can hand it out to them at the front desk, bring that back the next day, upload that to an interpreting service, have the physician read it and provide that diagnosis. So doctors, remember, you're going to say the same exact three things. You're going to give them their options and you're going to wait for their answer. It is possible they say nothing, and that's okay. We're not trying to pressure them. You guys are the clinical experts, the experts in the room, the trusted, well, you're the doctor. Keep it simple. You are the one who provides the next clinically appropriate steps to the patient, and they will trust that because it's coming from you. Just like when my doctor told me I need to go do a blood test. I don't like needles, and he didn't give me another choice. But that was the next clinically appropriate step when I asked him why I kept getting tonsillitis. Now, he didn't scream me for sleep apnea, because if he had, it would have resolved the tonsillitis. That happened later only as a result of my onboarding into this company. So, real quick recap, the 2-minute recap. Hygiene, do your bit. Find your 3 favorite things that are concerning about that patient. Communicate them with concern and tell them that you think it would be best if they did a test. Patient will say yes or no, no problem. Doctors come in the room, do your regular dental review. Doctor says, is there anything else we need to talk about? Hygiene, pregnant pause. Say the same exact 3 things you did in front of Mrs. Jones to the doctor. Doctor, take a few seconds, your own pregnant pause of sorts, review the information, look at the patient again, and provide to them the next clinically appropriate steps for patients who are considered to be at risk for sleep apnea, a home sleep study or a in-lab study. And wait, and some will say no, and that's okay. This is a serious thing, and I know it seems like kind of weird that we're going to put some design into our interaction, but our patients deserve our best foot forward. In this instance, that best foot forward is communicating with them that they need to take a test and helping them do this. Because if they go untreated, they will lose 7 to 10 years of their life if they're moderate to severe. What companies offer at-home sleep studies? If you give me 2 minutes, I can tell you that we do, but I'm not, this is an ad, but Awaken Sleep is one. There's lots of others out there as well. So we'll go through that in just a second as well. So with that, I want to open it up for any further questions. And I think I was able to wrap most of that up in time. And we're going to go through questions, and I'm going to ask the Plan Mecca team to share their link. And I'm going to, since you asked a question specifically about services, I can tell you Awaken Sleep does do interpretations, and they both also do home sleep study directly to patients. It's a zero-cost program that only costs the patient's money, and the patient pays Awaken Sleep, and then the Awaken Sleep supports them. So with that, if you guys could post that, there's the link, guys. So if you guys need to take off, go ahead. But if you want to stick around for a second, we actually have done something to reduce the barrier for entry for practices and patients. So if you stick around for just a second, we'll go through that. I want to give you guys a second for the AGD guidelines. Okay. Awaken Sleep, in partnership with our dental community, has developed a voucher program. Like I said, we are a home sleep testing company, and our mission is to go out there and make an impact with patients. And so we said we're going to ship dentist vouchers, 5 vouchers each at no cost to the dental practice. And so if you guys want your free vouchers, these vouchers give your patient $50 off of our testing service. There's zero cost to any dental practice getting involved. Text voucher to 111. You can order your vouchers there, and we will actually ship you these vouchers so that you can get involved with sleep and screening patients at no cost. So if we know that you come from this webinar, I'll even have them throw in a couple forms as well, just so you can make sure that you guys are doing that. Pediatric hygienist here. What are the main symptoms, concerns to look for in pediatrics? Should they be sent for a sleep study first or to an ENT? Great question. A lot of the similar signs and symptoms, there's other factors like moodiness, and really a whole nother class can be done on further comorbidities and concerns. But a lot of the things that you saw here are also indicators there. Acid reflux in children causes sleep apnea, not the other way around, so that one's going to be reversed. But for patients who are kids, they can do a home sleep study. There are 2 FDA-approved home sleep studies, and we have one here that we test kids with. And additionally, you can also send to an ENT. They may be better suited. A home sleep study may diagnose a child, but the treatment is going to be a multidisciplinary work of art. It's going to include their GP, it's going to include the ENT, and it's likely to include a orthodontist, pediatric orthodontist, who can look at the craniofacial structures. So great question, Michelle. Thank you. The last thing we want to share with you guys, and just really in partner with Plan MECA, is we have a promotion where we've decided to also discount our course. We have one left at this price point for the end of the year. And basically, it's a team training. It's a doctor and 4 team members. Usually it was $2,200, but in partnership with companies like Plan MECA, we've discounted down to $397. And so if you're interested in learning more about that, you guys can text SLEEP to 888-111. We have one more course, December 4th and 5th of this year at that price. So at the end of the day, guys, and I just want to be super transparent in saying this, we're here to help serve the community and offer more information like this so that your team can go out there and make the impact that only you can. This disease is killing people all by itself, not to mention the impact it has on compromising immune systems, not to mention the impact it has on shortening our lifespan or increasing the risk for other comorbidities. I had COVID this year, and I will tell you that I was only able to recover quickly because I was able to get sleep. I probably slept 2 days straight when I first got COVID, and if I hadn't been able to get good quality sleep, who knows what would have happened. So 80% of our patients are undiagnosed. 80% of the population that has sleep apnea is undiagnosed. We can do better. Sharon, thank you for sharing your score. And we hope that you guys take this information and use it in your practices. And we will be stoked to hear what's going on. Follow us on social media for more free content. And thank you, Plan MECA, our sponsor for this event. We had a privilege bringing it to you. So make sure you grab your link right there in the chat box. And Michael also promised I'd share the link to the ebook. So that is also there. It's not hyperlinked all fancy like, but awakenasleep.com/ebook. If there's anything we can do to help you guys help more patients, please let us know. We're here to serve you guys. We're here to make a difference together. Thank you guys, and we'll see you guys next time. Have a great evening.
Chad, thank you so much for all of that wonderful information, and thank Michael for us as well. Everyone have a great night, and thank you for attending this webinar. And you should have that link there, and use AGD code 200 to get your digital CE for this evening. Thanks again for joining us. Everyone have a wonderful night.